Hello guys, so how are you all? So today we shall be discussing the upper limb part. Okay, so yes, hello Vanilla, hi Aditya, Raj, hi Pavani, good evening Pavani, Osama Sheikh, good evening. So let us wait for 2 more minutes and then let's start. Okay, right, let me put up the heading by then. Hi Madhavi, hello. Sana Joy, hello. Nandan Goswami, hi. Hello Benedict, I'm fine, thank you. Pallavi, good evening. Mohammad Nuvesh, hello. Right. So I hope all of you who have attended the previous session on the lower limb, I hope you have revised it, right? Yeah. Before we start upper limb, I just want to ask you that have you revised it? Aarti Sankar, hi. Thank you, Benedict. Thank you so much. Nissi Marapatla, no, you haven't revised it, so you have to revise it. But anyways, upper limb and lower limb, we are not combining it. They both are different. So after teaching complete upper limb, so I would request you to better revise both of them. Okay. So Mohammed Aleem, good evening. Right. So why don't we start? Right? Shall we start? Shall we start the session? Yeah. Okay. Fine. So that's a green signal from you. Fine. Fine. Yeah. So guys, upper limb, right? I'm not sure how you understood lower limb, but I'm going to teach you upper limb super clearly. Okay. So you will understand upper limb like you have never ever studied before. So what I want you to do is that you just have to reply whatever I ask you, right? You have to be with me till the end of the session. And second thing is that wherever I tell you to stop making notes, you just have to stop making notes. Okay. Because some of the things are a little bit difficult, tricky to understand, right? So anyways, we shall today discuss not only the general part of an upper limb, I will relate everything I speak with the clinical points. Clinically in the hospital, how do you apply? Clinically in an X-ray, how do you see? Clinically, how do you see a patient with this kind of deformity and all? Everything will be clinical oriented because you are about to write an exam called next, right? So which is completely clinically integrated, right? So I'll go through everything and even I'll show you the questions which are already asked from the topics which I teach. Okay, right. So let's start now. Let us start a little introduction, guys. Introduction is that, not my name and all, but introduction is that during the intrauterine life, okay, Khan, hi, Shah Nizamuddin, hi, hello. So we are starting a session here. Khan, introduction is that during the intrauterine life, you got some things in the baby. Okay, so what are those things? Look here. During the intrauterine life, you got this thing. Now, what is this thing? What is this thing consisting of, guys? What is this thing consisting of is nothing but, see, this is called as ectoderm. This is called as ectoderm. Okay. And the down one, ectoderm, and the middle one is called, middle one has to be called, see, this middle one has to be called as, yes, that should be called as mesoderm. You know, we have got the three germ layers, right? Ectoderm, mesoderm, and the final one is your endoderm. And final one is your, very good, Dr. Benedict, is your endoderm. Okay. Now, look here very carefully. This groove, whatever is there, right? So previously it used to be like this. Previously it used to be like this, but now there is a small groove that is formed inside, right? So this groove, whatever it is there here, this is called as neural groove. This is called as neural groove. Okay, why am I telling you this? Because there are MCQs coming from this. Okay, neural groove, in the future it will form neural tube. I'll also draw that, don't worry. It will form neural tube. And another important thing is that on the edges of these neural tube, you have got a group of cells on either sides. These group of cells are called as neural crest cells. Excellent, Khan. You're perfect. Excellent. Everyone is perfect. Khan Amin, you're right. Ectoderm, mesoderm, and endoderm. Very good, Khan. Very good. Very good, Bentek. These are neural crest cells. Okay. And here down in the center here, whatever you see here, this is called as notochord. What is this called? This is called notochord. Now look here, guys, what will happen? This is the neural groove. Here I have neural crest, here I have neural crest. Later on, what will happen is that both the edges, they join together and completely there is a opening, a hole here, right? Now what is this oval opening? Look here. All of you know this is ectoderm, this is mesoderm, and this one is endoderm. So what I was telling to you is that these both edges, guys, these both edges, look here very carefully, these both edges, they come together. Once they come together, they join and they form so what called as neural tube. Neural groove will join together to form neural tube, as I have already told, right? So this is neural tube. Then where are the neural crest cells? See, these green color things are the neural crest cells. Where are these neural crest cells? Neural crest cells are adjacent to it. And where is the notochord? Notochord is just below that. This is your notochord. Why are you telling these things to us now? Why am I telling you is that within the mesoderm, you have got some areas. Within the mesoderm, you have got some areas. For example, let us say completely lateral side on the edges, completely on the edges of the mesoderm, whatever mesoderm I have drawn there, completely on the lateral side edges, they are called as lateral plate mesoderm. So this is called as lateral mesoderm. Okay, so what this should be called as, I'll write it down here. This is called as lateral mesoderm. I'm not teaching you embryology now. Okay, so this is called as lateral mesoderm. Second important thing, now concentrate very carefully here, very carefully. Exactly nearer to the neural tube also, I have got a piece of what? A mesoderm. Exactly on either side of neural tube, I have got a piece of, exactly on either side of the neural tube, I have got a piece of what? Mesoderm, and this is called as paraaxial mesoderm. Paraaxial mesoderm, right? So I hope all of you are clear till now, right? Paraaxial mesoderm. Fine. Paraaxial, excellent, very good. Paraaxial mesoderm. Okay. Now, between the lateral mesoderm, thank you so much, Khan. Thank you so much. I will teach you, right? I'll teach you the embryology, right? I'll teach you the embryology completely, but let me complete this upper limb so that I'll completely teach you embryology in the later on sessions. I'll teach you excellently. You won't even forget, right? So we have got lateral mesoderm, we have got paraaxial mesoderm. In between lateral and paraaxial mesoderm, whatever mesoderm I will have, I will call it as intermediate because it is in between both of them, isn't it? So this mesoderm is called as intermediate mesoderm. This mesoderm is called intermediate mesoderm. And by the way, yes, even I will teach neuroanatomy, Pragnya, definitely. Rehana Akhtar, you're right, it is intermediate mesoderm. And one more thing before I continue, I just want to tell you one thing, guys, that this Sunday also we have got a session. Okay, even this Sunday also we have got our session. We'll have session this coming Sunday also. So do you want me to teach anatomy or do you want me to teach microbiology? Because we haven't discussed microbiology for a while. So we are planning to discuss microbiology this session evening at 6 o'clock. So will it be okay for all of you to join the session? Yeah, the micro session. We are planning to take a micro session this Sunday evening at 6 o'clock. Will you all join? Will you all join for the micro session? Anatomy we shall discuss again later on in the next session. Will you all join? Will you be able to join, or do you have any other works, or should we postpone it to another day? Right. Anyways, so most of your messaging, but what we'll do is that I'll put a poll. Okay, I'll put a poll here whether you want or not. So based upon the percentage of your votes, then we shall decide. Okay, right. So let us get back to the topic. Right. Why I'm asking you this is that because we have a Diwali function on Monday, right? So you might be busy on Sunday. So, but that is the reason why we are asking this, or else we usually keep the sessions on Sunday. So that is the reason why. Anyways, we'll put a poll. Everything is based on your decision, guys, whatever it is. So, right. Anyways, so far what you have learned there is something called notochord. On either sides you have got lateral mesoderm. Then you have got paraxial mesoderm. In between both of them you have got intermediate mesoderm. Now look, why did I teach you this? Why did I teach you this thing is that this lateral plate mesoderm, very important MCQ. Lateral plate mesoderm is the one in future it will develop into upper limb and lower limb. For example, if I divide this lateral plate mesoderm into two parts, the upper one will develop into upper limb and the lower one will develop into lower limb. So what is the embryological origin of lateral plate what is the embryological origin of upper limb or lower limb? If they ask you in the exam, you have to tell it is lateral plate mesoderm. Okay, lateral plate mesoderm. So lateral plate mesoderm develops into upper limb and lower limb. I hope all of you are making notes, guys. Making notes. Please make notes. I'll tell you when to stop. Second important MCQ is that, then what about, you also taught us some extra things like paraxial mesoderm. Yes, paraxial mesoderm in the future it is going to develop into your skeletal muscles. You know, all your skeletal muscles, what do you have? All of them are developed from the paraxial mesoderm. Skeletal muscles. Next important thing is that, then what about intermediate mesoderm? Simple thing, guys. If I am dividing the body into two portions, like from the abdomen till the head, this is one portion. From the thighs till the foot, it is another portion. What is in the center? In the center you have got genitourinary system. So intermediate mesoderm is in the center. So center one develops into the center things. What are the central things? They are your genitourinary system. Right? So remember in that way. Intermediate mesoderm will develop into what? Genitourinary system. Genitourinary system. I'm telling you guys, even if you don't remember all these explanations which I've given you, but at least remember this box. Because definitely, guys, if they'll ask you a question, there is a high chance, I'm not telling you definitely you'll get a question, but there is high chance that questions can come from this. Pakka. Okay? Right. So definitely. Now, you told me that lateral plate mesoderm will develop into upper and lower limb. Fine. So can you tell me at exactly which week of gestation will the upper limb development start? What am I trying to tell you is that the development of upper limb development of upper limb starts. When does the development of upper limb starts? Do anyone have any idea? HS Vlogs, good evening from Pakistan. Hi, good evening. Good evening. Thank you so much for attending my session. Yeah, do anyone have any idea that at which week of gestation do this upper limb usually develops? Fine, no worries, no worries. Right, no worries at all. So it basically develops from the end of 4 weeks. End of 4 weeks or beginning of the 5th week, the upper limb development start. So you are telling me upper limb. Can you also please tell me lower limb? When does the lower limb development start? It starts from the starting 5th week. Okay, it starts from the beginning of 5th week. Beginning of 5th week. So these are the MCQs, guys. I just want to tell you, I did not really enter into the topic right now. These are the MCQs which you definitely have to know. Okay, one has to know these MCQs. Right. So till here, if you understood, then I will shift to the next topic. I mean, I'll start discussing the upper limb. I shall be discussing the bones, the ossification centers, the muscles, the nerves. It is going to be really super interesting. So did you understand here before I start? Yeah, HS Vlogs, you understood? Dr. Benedict, Osama Sheikh. Thank you. Right. So Sanyasi Pandit, hi, hello. So Nisi, hi. Rehana, fine. Anjana Paul, yes, thank you. So let us start now. Let us start now. In the upper limb, what are the things you basically see, guys? See, this part is called as a beautiful breastbone. You know, what do you call it as breastbone? Aditya Boshle, love from Georgia. Thank you so much. Dr. MHB, interesting bullet points. Thank you. Thank you so much. Right, let's start now. Let's start now. Okay. This is called as your sternum. And next important thing is that all the way attached to your sternum, you have got a very beautiful bone. Right? What is this beautiful bone which you have? You call this as your clavicle. You call this as your clavicle. Next important thing is that you even have this bone over here. Can anyone tell the name of this bone, guys? What is the name of this bone? Right? From the anterior side, I can see a small process like this. This is called coracoid process. From the back, I can see another process that is coming all the way like this. This is called acromion process. Very good. Excellent, excellent, excellent. So this is your scapula, right? This is your scapula. Now, from the anterior side, whatever you can see, this one, right? So this is called as your coracoid process. Okay, whatever you can see, this is called as your coracoid process. On the back of the scapula, this is called as the spine of the scapula. What is this called? Spine of the scapula. And spine of the scapula has got a projection like this. This is called acromion process. This is called acromion process. Why are you teaching us osteology? Why am I teaching you osteology is later on I will tell you the muscles, attachment and insertions. That time you have to know what is acromion process, what is coracoid process and all. I'll simplify it. Okay, don't worry. Right. What is this called? What is this called? Yes, tell me. This is called as your glenoid cavity, right? This is called as your glenoid cavity where your head fixes here, isn't it? Why am I telling you about glenoid cavity is glenoid cavity has got two parts. On the top here, on the top, I'm not sure if you can see this, right? On the top here, this is called as supraglenoid tubercle. Above the glenoid, supraglenoid. Below the glenoid, infraglenoid. Infraglenoid tubercle, supraglenoid tubercle. Coracoid process, acromion process, spine of the scapula. That's it. Other than that, you need not know, there is no need for you to know anything. Okay. So this is your glenoid cavity. Okay. Now let me draw a beautiful humerus. This is your humerus bone. Okay. Very good, guys. HS vlog, supra and infraclavicular tubercle. You're right. Khan Amin, you're right. Damodar, thank you. Thank you so much. SKM, thank you so much. Yes, you are my student, I think. There, right. So look here. Look here now. What is my main intention to teach you is that there is a joint that is connecting clavicle to sternum. Okay, there is a joint that is connecting clavicle to sternum. This is called sternoclavicular joint. This is called sternoclavicular joint, and this joint connecting acromion process. All of you know this is called as acromion process. Acromion process. So connecting acromion process to clavicle, this is called acromioclavicular joint. What is this? Acromioclavicular joint. Okay. Next important thing. And by the way, this is called as your coracoid process, right? Coracoid process. Right. So did everyone understood whatever I told you? Very good. Acromioclavicular joint. Did everyone understand my explanation? Yeah, you understood my explanation, whatever I've taught you right now? Birappa, very good. Very good, right. Now the topic starts. Clavicle. Now in this clavicle, all of you know that this clavicle is a S-shaped bone. Clavicle is a S-shaped bone, right? Now all of you look here, guys. All of you look here. Please don't write anything. Khan, Amin, thank you so much, but no comparison with him, right? Right. So he's completely different. So regarding the clavicle, I just want to tell you that how did clavicle develop? How did clavicle develop is that in the center of the clavicle, I have got these two small dots. These two small dots are called as primary center. What are these two called? These two are called as primary center. Primary centers of the clavicle. Okay. And on the edges of the clavicle also, I have got one dot here, another dot here. Now this is also called as secondary center, and this is also called as secondary center. So how many primary centers do we have in a clavicle? We have got two primary centers. How many? Two. How many secondary centers we have got? We have got two secondary centers. So these are the centers of ossification. What do I mean by that? What do I mean by that is that, guys, look here. What do I mean by that is, keep this thing in mind. What do I mean by that is, what is primary center in the sense, this is the point from where the bone starts developing. Okay. If for example, here I have a primary center. This is the point from where this entire pencil starts developing. Okay. This is the point where the cells, they become enlarged. They group themselves and finally form a bone. In other way also I can tell you like this, that if there is any defect, in these primary centers, then the bone development will not happen. Okay, so these are called as ossification centers. In a clavicle, you have got two primary centers, what are those two? Two secondary centers. Okay, so this is the important thing. Now, what is the MCQ that can be asked? Very, very important box I'm writing now. What is that? You might ask, sir, when did these primary centers develop? Okay, you told me that during the uterine life itself, right, as the baby is developing inside the mother's womb, that is called as the uterine life. During that life itself, these primary centers will develop. But exactly tell me which week. Primary centers will start developing at 5 to 6 weeks of intrauterine life. They start developing at 5 to 6 weeks of intrauterine life. They start developing at 5 to 6 weeks of intrauterine life. This is a repeated MCQ, guys. Very, very important. Okay. Next important thing. And sir, you also told me there are secondary centers on each end, right? Let us say this is the place where, let us say this is the place where I had my sternum. So I call one end as sternal end, one end as clavicular end. Okay, so this is called as the sternal end. Can you tell when does the secondary ossification start in the sternal end? Look here. Sternal end, and the other one is clavicular end. Right? So this is your sternal end. Here it starts at 19 to 20 years, after 19 to 20 years. Whereas here it starts on 20th year. On 20th year. Okay, so these are the MCQs which you have to remember. This is a question, this is a question, and this is also a question. Right, so you understood so far now. Right now I'm going to tell you one very, very interesting and a clinical point, guys. Very important point. Did you understand till here? You know why did I tell you this? First important point, first important thing is that they will ask you MCQs in the exam. Second important thing is that it has also a great clinical importance. What is a great clinical importance is that I told you in the starting, if ossification centers are not properly developed, if there is a defect in the ossification centers, then the entire bone development will not happen. So if, let us say, there is a defect, let us say there is a defect in these ossification centers. So as a result of this defect, then there is no further development of clavicle. No further development of clavicle. So if clavicle, in some patients, ossification centers will be there, they will grow like this, they will grow like this, and suddenly there will be a defect and the development of clavicle stops. In some group of patients, completely the ossification centers, they don't even appear. So what will happen in that case? If you look at a baby, you will see incomplete development of clavicle in some patients, or at least some part of clavicle is there, a little bone of clavicle is there. So this is called partial or complete underdeveloped clavicle. Underdeveloped clavicle. You know what is this condition called as? This condition is called as cleidocranial dysostosis. This is called cleidocranial dysostosis. You have to remember, guys, super important. Cleidocranial dysostosis. This is called cleidocranial dysostosis. Partial development or complete underdevelopment of a clavicle, or I can also say incomplete development of a clavicle is called. Very good, HS vlogs, very good. Love from Andaman and Nicobar Islands, thank you so much, thank you so much. Love from Karnataka, thank you so much. Cleidocranial dysostosis. Let me show you a picture, guys. Let me show you a picture. It will be very interesting. Look at this patient here. Look at this patient. Look at this patient here. His left clavicle is normal, right? But look at his right clavicle. Can you look at his right clavicle there? No. I mean, even there is a little bit defect in the left clavicle. I don't want to confuse you by showing that. But right clavicle is completely underdeveloped. So when there is no clavicle, the shoulders cannot be widespread like this. When there is no clavicle, the shoulders will close each other. You know why? Why does the shoulders close each other? Let me show you another picture. Right, look at this kid. He is completely not having a clavicle. At least the patient one was having a little bit clavicle because of some development, but second patient is completely not having clavicle. You know what will happen? When there is no clavicle, here you have got a bone exactly in the place of my hand. You have got a bone called as pectoralis major muscle, right? Sorry, not a bone. The muscle called as pectoralis major muscle. So this muscle, guys, this muscle attaches to the clavicle, attaches to your sternum, and even attaches to your humerus. It attaches to your humerus. So when I don't have clavicle, if this muscle is contracting like this, what is happening? My humerus is coming medially like this. So when this muscle also contracts, both the humerus, they come medially. This is because of, right, both the humerus bones, they touch each other. Almost they touch each other because of the contraction of pectoralis major. Okay, but I don't want to go that deep for you. What you have to remember is two things. We have got something called ossification centers. If there is a defect there, I will come across cases like cleidocranial dysostosis. And why the both of them are touching, both the shoulders are touching, it is because of the pectoralis major muscle, okay, which is contracting both the shoulders. Till here, did you understand? Did you understand, guys? Very good, guys. Thank you. Thank you so much. Thank you. Look here. Clavicle, and again your beautiful sternum. So look here, wherever there is sternum in the center, this is called as a medial end, that is called as a lateral end, right? So this will be the medial, this will be the lateral. So it means this is the medial region, right? This will be the lateral region. This is a favorite MCQ, guys. I mean, they won't ask which is medial and lateral, but in fact, what they'll ask you is, what is the most common bone that is fractured in your body? That is clavicle. Okay, clavicle is your collarbone. That is the most commonly bone which is fractured in your body. Exactly which part it is fractured? Is exactly here. So it is fractured at medial 2/3 and lateral 1/3. Medial 2/3 and lateral 1/3. In between that, there is a fracture of clavicle. Okay, so most common fracture of clavicle, most common fracture location of clavicle, that will be what? Medial 2/3 and lateral 1/3. I will also, guys, as I'm teaching you, I will also make you to do MCQs. Don't worry, I already have MCQs kept here. I'll make you to do. Which is the most common fractured bone in the body? That is clavicle. Excellent, Osama Sheikh, you're right. Medial end is quadrangular. He's right. Medial end is quadrangular, lateral end is flat. Perfect. Birappa, you're also right. Rahman Rohan, meeting point of two curvature. Excellent. You can also tell like this. See, when I this is something called as S shape, right? So this is a curvature, this is a curvature. So exactly at the meeting point of those both curvatures, there is a break. You are perfect. Rahman, you're right. Right. You understood one clinical point, right? So why don't we do a question, guys? Why don't we do a question before we proceed? Okay, before we proceed, we will just do a simple question. Okay, I'll teach you one more thing and then we shall do a question. Okay, I haven't put the question yet. I'll teach you one more thing and I'll do a question, because it will cover two questions. So we are done with clavicle. All those which I've taught in the clavicle are enough. From there only the examiners will ask you the question. Don't worry. Now we shall discuss about the scapula. Now I am looking at a scapula from the back side, right? It means now you are looking at a scapula from the back side. So if you are looking from the posterior aspect, how does the scapula look? This is how a scapula looks from the posterior side. Now I don't want to mention everything, guys. You know that this is AP. AP means acromion process, right? And this one is called CP. CP means coracoid process. And I'm putting some points here. This is called supraglenoid tubercle. This is called infraglenoid tubercle. Okay, one is called supraglenoid tubercle. and the other one is called as infraglenoid tubercle, and in the center you have got the glenoid cavity, and no fun in telling that this is also called as spine. Okay, sir, can you tell me where are the ossification centers here? Where are the ossification centers? Where are the ossification centers? Look here, very keenly look here, guys. There are two ossification centers on the acromion process. I'm writing now. Acromion process, I have got two ossification centers. I have got two ossification centers on coracoid process. Coracoid process also have got two ossification centers. I have got one ossification center here. Now what is this here, in the sense what? What is here? This is a medial angle or lateral angle? Tell me. Yeah? Anyone? See guys, if this is a scapula, okay, now which scapula is this? Which scapula is this? If I'm putting this scapula backward like this will be the scapula of my left hand, right? Left hand. This is where the humerus attaches, right? So this entire region is the lateral. This entire region which is facing towards my spine. In the center I have got spine, right? Towards my spine is the medial. So this is called medial region of scapula. Medial angle of scapula. This is called inferior angle of scapula, and this is called as a lateral angle. Okay, again medial, inferior, lateral. Now you tell me what will be this? Medial, inferior or lateral? This will be the medial side. Excellent, Birappa, Benedict, perfect. Medial side. Medial side, how many ossification centers I have? Only one ossification center in the medial side. Next, in the inferior angle, in the inferior, I told you this is inferior angle, right? In the inferior angle also I have got one ossification center. Inferior angle also I have got one ossification center. Next important thing is that, look here very carefully, in the infraglenoid tubercle, also I have got one ossification center. One ossification center. Fine. One ossification center. Did you understand? Sir, you told me there are two ossification centers in the acromion process, two in the coracoid process, one in the infraglenoid tubercle, one in the medial angle, one in the inferior angle. But tell me, what are these ossification centers? Are these primary or secondary? You told me in the starting there are two types of ossification centers, primary and secondary. All these ossification centers which I have just told you are secondary ossification centers. They are what? Secondary ossification centers. Okay, so all which I have drawn in red color are secondary ossification centers. Then where is primary ossification center? Look here. Primary ossification center is located in the middle of scapula. This is your primary ossification center. Rehman Rohan, you are right. Body of the scapula. In the middle body of the scapula, you have got the primary ossification center. Okay, fine. So you told me ossification centers. Very good. Can you tell me any clinical point which is associated with this? Yes, there is a clinical point. What is a clinical point is that usually guys, in you and me, the clavicles, they are developed in the cervical region. Okay, clavicles are developed in the cervical region. Now from the cervical region, what will happen is that these clavicles, they descend down. Clavicle is developed in cervical region and they descend down. Okay, usually in you and me, they descend down. But in some cases, what cases? In those cases called as congenital cervical abnormalities. Some cases like congenital cervical abnormalities, what will happen is that both the scapulae, they don't descend down. One scapula remains there and the other scapula descends down. So how does the shoulder look? The shoulder looks like this. Okay, so let me write it and show you a picture that what is a clinical point here? Clinical point is that around 9 to 12 weeks of gestation, around 9 to 12 weeks, what will happen is that both the scapulae from the cervical region, they descend down. Scapulae, they descend down. Scapulae, they descend down. during 9 to 12 weeks. But in some cases like congenital cervical abnormalities, some cases like congenital cervical abnormalities, I'm also giving you an example of that. Example of a cervical congenital abnormality, that is Klippel field syndrome. Klippel field syndrome. In some cervical abnormalities like Klippel field syndrome, this problem is associated in those patients. The cervical region is completely abnormal, so that it does not allow the descending of this scapula. It does not allow the scapula to descend. It will keep one scapula with itself and tell other scapula you can go down. Okay, so this deformity where one scapula is above, one scapula is below, this is called as Spiegel's deformity. What is this called? This is called as Spiegel's deformity. Spiegel's deformity. Let me show you. Look at this picture over here, guys. Look at this picture. One scapula is on the top, but one scapula is under normal position. See, this is normal. This is normal, but whereas one scapula is above. You see? So this is called as Sprengel deformity. This is called Sprengel deformity, right? So this would be the way, right? Sannyasi. Right. So you understood? Everyone understood? Yeah? Everyone understood these two clinical points, guys? Thank you. Thank you so much. Thank you. Thank you. Thank you. Right. Now it's time for you. It's time for you to do the question. Okay? Question, let me tell question number 1 and question number 2. Now look at the question number 1. Look at question number 1. Look at question number 1. Come on, guys. Let's look at these questions. Sumit Gurjar, I'll definitely take a class on spinal cord. I'll discuss entire anatomy. Don't worry. Okay. Right. So let us concentrate on the question now. Look at the question first. A 5-year-old patient, look, he's a kid. 5-year-old patient comes to the orthopedic clinic with shoulder asymmetry. Shoulder asymmetry means, you want me to zoom? Okay. I'm sorry, guys, I cannot zoom further. Right, but anyways, I'll try. Shoulder asymmetry and limited abduction. The parents explain this deformity has been present since birth. It is present from birth. And now the child is unable to reach overhead and practice in play. On examination, look here, the left scapula is elevated with medial rotation of the inferior pole. Right? Which of the following is associated on further imaging? So what is he talking about? He is telling from birth there is shoulder asymmetry. One scapula is above, one scapula is below. Right? So what is he telling? Absent clavicle. Is this the answer? I don't think so. Absent clavicle is not an answer. Spina bifida? No. What is the answer? Cervical spine abnormalities. Exactly speaking, he is talking about Sprengel's deformity. Right? Sprengel's deformity. Horseshoe kidney? No. Proximal humeral deficiency? No. All these things are not there. Okay? Right. So which of the following is characterized? Which of the following is characterized by failure of scapula to migrate caudally? Failure of scapula to migrate caudally down during fetal development. During fetal development means which week, guys? I told you during 9 to 12 weeks. The scapula has to go down caudally, not till the tailbone. Okay? Caudally means downward. So which syndrome is this? Answer, all of you. Osama Sheikh, Aziz Physio, Diva. right? Sri Bardhan, all of you are right. All of you are right. All of you are right. Excellent. Excellent, Osama. Rahman Rohan, excellent. Osama Sheikh. HS Vlogs, Harshita. Excellent. So the answer would be Sprengel's deformity. Sprengel's deformity. Very good, guys. Super, super perfect. You're super perfect. Right. Thank you so much. Excellent. So let me tell you one thing, guys. You know what are these two questions? These two questions, one was asked in your FMGE exam. One was asked in your FMGE exam. See this one. The second question was asked in your FMGE exam, whereas the first question was asked in your USMLE exam. I don't know the dates, but first question was asked in USMLE, second question was asked in FMGE. Okay. So you guys have answered these two questions. So this is the way, guys. If you read everything by practicing, by looking at it, by imagination, definitely you can answer any question. Believe me. Right. Now, so let us discuss much more interesting things, guys. Let us discuss much more interesting things. Poland syndrome. Someone asked, what is Poland syndrome? Where is it, by the way? Right. Poland syndrome means, see, Poland syndrome means, you know, in your body, the muscles are symmetrical. If I have right side pectoralis, I will also have left side pectoralis. If I have right side subclavius, I will have left side subclavius. So both the muscles are always, all the muscles on either side of the body are symmetrical. But in Poland syndrome, what will happen is that one side, absolutely there will be no muscles. Absolutely, there will be no muscles one side, right? If you want, I can show you a picture. I'll show you a picture as well. Look at this patient. Now, this is a male patient, right? Male patient. Look here, one side, he is having muscles, but one side there is hypoplasia of all the muscles, isn't it? This is called Poland syndrome. Very good. Christopher, you're right. Bardhan, Sri Bardhan, you're right. Osama Sheikh, you're absolutely right. You're absolutely right, Osama Sheikh. Fine. Let us continue, guys. Let us continue now. Let us continue. We are done with clavicle and scapula. Now we shall be discussing about humerus. When I discuss about the muscles, guys, you will fall in love with these muscles. I'm telling you. So let us discuss about humerus. So this is your humerus bone. Okay. This is your humerus bone. This is called as your head of the humerus, and let me just give me a minute so that I can finish my picture. Right. So this is all I wanted to draw. Nothing more than this. Nothing more than this. Very fastly, I'm telling you. This is called as your head. This is called as what? That is called as your head. And I'm tying a ring around this. Look here. I'm tying a ring around this. This is called as surgical neck. This is called as surgical neck. Why am I stressing it? Because most commonly the fractures of the humerus happen to the surgical neck. Okay. If there is a fracture to the surgical neck, there will be a nerve that will be involved, that is axillary nerve. I will tell you in detail about that, but right now what you have to know is that that is surgical neck. Okay. And this is called as deltoid tuberosity. Deltoid tuberosity. This is called deltoid tuberosity. Right. And this round part is called as capitulum. Capitulum. And this part is called as trochlea. This is called trochlea. Okay. So this is your humerus. This is your humerus. How do I hold my humerus? Look at the lesser tubercle that should face you. It means this is the humerus. I think this is what? This is the right humerus. Okay. This is called as a head. And this part where I'm holding right now, this is called as the surgical neck of the humerus. Surgical neck of the humerus. This is the shaft. Look here. Here you have got two parts. This round part is called as capitulum, and this part is called as trochlea. Capitulum and trochlea. This is called, what is this called? Lateral epicondyle. What is this called? Lateral epicondyle. And what is this part called? This part is called as medial epicondyle. Compare medial epicondyle with lateral epicondyle, guys. Medial epicondyle is much more developed, much more prominent, right? Don't be happy that this is much more prominent, because out of two, out of lateral and medial epicondyle, if someone asks you, medial epicondyle fractures are more common than lateral epicondyle. Okay, medial epicondyle fractures are more common than lateral epicondyle. Clear? Now, if I turn it posteriorly, I will find a small hole here, not hole, like a fossa. This is called olecranon fossa. This is called olecranon fossa, which looks like O. O for olecranon fossa. Okay, right. The most important thing you need to know is that exactly on the humerus bone, you have got two lips like this. Two lips. Okay, two lips. Now, what are these two lips? This is called as medial lip of humerus. And this is called, listen very carefully, guys. From here, n number of MCQs will start. This is called lateral lip of humerus. Medial lip and lateral lip. Then what is in between? See, it is like this actually. This is medial lip, this is lateral lip. And what is this groove? This is called as bicipital groove. What is this called? This is called bicipital groove. Bicipital groove. Why are you teaching us anatomy? Because right now I'm going to tell you one very important thing. Right? Later on I'll draw and tell you. But right now let me tell you this thing, that the muscle that is attached to medial lip and the muscle that is attached to lateral lip. Okay? Muscle that is at, see, your upper lip and lower lip, both are important for you. Both are major. They play a major role in your life. So medial lip and lateral lip both are attached by two major muscles. Two major muscles. What are these two major muscles? Look here. Remember like this. M-E-T. What is this? M-E-T. T stands for teres. So what are the two majors, do you know? One is teres major and another major muscle, yes. After teres major, we also have another major muscle. HS Vlogs, you are absolutely right. Intertubercular sulcus. Yes, he is telling, HS Vlogs is telling that this is greater tubercle, this is lesser tubercle. In between both the tubercles, I have got a sulcus. This is called intertubercular sulcus, which is also called as bicipital groove. You are perfect. You're right. Very good. All of you, very good. Birappa, Benedict, Vanilla, all of you are right. It is pectoralis major. So all of you will confuse where to put the major muscle. Sometimes you might be confused telling that medial lip has got pectoralis major. So to prevent that confusion, I'm telling you, remember it as met. You meet someone, right? You already met someone. T stands for teres major and the other one will be pectoralis major. Easy, right? Bicipital groove, what muscle? I'll tell you later on. But remember till here. Clear? Very good, Birappa. You're perfect. It is, yes, I'll tell you, Birappa. I'll tell you what is that. Okay. Now, guys, don't write anything now. Don't write anything. Put your pens down. Now, look at my explanation. Look at my explanation. Look here. This is your humerus, right? This is your humerus. Very, very high yield, guys. Very, very high yield. Very, very high yield. Look here, all of you. I told you this part is your surgical neck. This part is your surgical neck. Exactly here you got a nerve. You got a nerve that is running like this. This is called axillary nerve. Axillary nerve. What is this nerve? This is called axillary nerve. I'm just telling you three functions of axillary nerve. I mean, when I will tell you brachial plexus, I'll teach you in detail. But right now, just remember three functions of axillary nerve. One is abduction of your arm. Abduction. I told you previously how to remember abduction, adduction. LAB, lab. L stands for lateral, AB stands for abduction. It means if I'm moving my hand away, it is because of my axillary nerve. Okay, abduction of arm. Second and third important thing is that on the deltoid muscle, I can feel the sensation, right? So sensation on the deltoid. Not only that, sensation on the lateral side of my arm. So if this is my arm, right? This is the medial side. This will be the lateral side of my arm. Sensation on the lateral side of the arm. Axillary nerve. By chance, if I come across a patient who is having fracture of the surgical neck, okay, fracture of the surgical neck, if I see a patient having fracture of surgical neck, then axillary nerve will be damaged. If axillary nerve will be damaged, the patient will tell, doctor, I cannot lift my hand, I even can't feel any sensation here. If someone is touching, I can't even feel any sensation. You know, these are the complaints. Okay, so in which case is this nerve damaged, guys? In case of surgical neck fracture. Surgical neck fracture. I'll show you the x-ray. You will tell me that, you will diagnose and tell me, but let me just finish it up. Next important thing. On the surface of humerus, I can find a groove like this. You see, I can find a round groove like this. It means this is the humerus. I can find a groove like this going back. This is called as a radial groove. Okay. Why it is called radial groove? Because a special nerve called as a radial nerve passes like this. Okay. So this is called radial groove. Within the radial groove, you come across, yeah, very good. HS vlogs, you can also call it as spinal groove. You're perfect, right? Radial nerve. Okay. Now, where is this radial groove located? In the middle of the shaft. So, if there are mid-shaft fractures, then there can be damage to the radial nerve. Isn't it? What kind of fractures there will be damage to the radial nerve? Mid-shaft fractures. Mid-shaft fracture of humerus. You know, this is how you talk in the hospital. A patient, sir, this patient is having mid-shaft fracture of the humerus. It means there is damage to the radial nerve. If there is a damage to the radial nerve, what will happen, guys? What will happen? There will be a claw hand, or what will you see in a patient? Claw hand or wrist drop? Yeah, I want your answers. Perfect, Harshita, Bardhan, Vishwas. No, Vishwas, it is not claw hand. Venala, Angita, Cyanide, Sanyasi Pandit, everyone, perfect. So this is wrist drop. This is wrist drop. Okay, and another important thing. I told you that this is medial epicondyle, this is lateral epicondyle. Exactly, guys, exactly. A nerve is coming like this, it passes behind the medial epicondyle, not in front. It passes behind the medial epicondyle, and that nerve, look here, it comes all the way like this and it passes just behind the medial epicondyle, and this nerve I call it as ulnar nerve. If I have damage to ulnar nerve, why will I have damage? Whenever there are medial epicondyle fractures, when will I have damage? Whenever I have medial epicondylar fracture, I will have damage to ulnar nerve. Ulnar nerve damage, Dr. Bendig, you are perfect. You're right. You're absolutely right. That ulnar nerve damage will lead to claw hand, not Mallikarjun, not wrist drop. Wrist is radial. Remember it as like this. R for R. Okay. So right now I'm telling you about claw hand. Exactly speaking, ulnar claw. Remaining fingers will be right. Only the ulnar part will be like this. Ulnar claw. Okay. ulnar claw. Ulnar claw. Right. The last one, that there is a nerve that is coming from the center. Center is called middle. Middle means median. It is called median nerve. This is called median nerve. Can anyone tell me, whenever there is injury to median nerve, what kind of problem will I have? Yes? What is the nerve injury that is associated with median nerve, guys? Aniken, you are right. Yes? Tell me. Okay, I'm putting up that question to you. I'm not telling you this. I'm putting up that question to you. You will answer me at the end. At the end, I'll ask. See, carpal tunnel syndrome, I agree. That is compression of median nerve. Compression of median nerve will lead to carpal tunnel syndrome. Right, anyways, I'm putting up this to you. Cool. Now, look here, you will answer me at the end. So, from here, guys, a bunch of MCQs can be asked. Right? As the paper is getting clinical day by day, right? Year by year, they're setting clinical papers. They won't directly ask you, okay, surgical neck is fractured. What problem will the patient have? These are olden days questions. But now they are not asking like that. They'll directly give an X-ray and tell me what problem, what nerve injury has happened in the patient. They will directly give you an X-ray of a fracture and tell what nerve can be damaged there. So overall, guys, surgical neck, axillary nerve is gone. Midshaft fractures, radial nerve is gone. Medial epicondyle fractures, ulnar nerve is gone. Okay, ulnar nerve is gone. Look at the pictures now. Look at the pictures. Now, all of you stop commenting. I will ask you the question. I'll show you an X-ray. You will tell me which nerve is injured. Okay, which nerve is injured? You will tell me. Right. Now, who will tell me which nerve is injured in this X-ray, guys? Which nerve is injured here? Yes. Perfect. You're all perfect, guys. Very good. Gangani, you're right. Vanilla, you're right. Cyanide, Bardhan, Aniken, Harshita, Rehan, Rehana Akhtar, all of you are right. You see, you can very clearly see a fracture here, right? So this patient is having axillary nerve. This patient, I'm not telling he will have, he might have axillary nerve damage. Due to what? Due to surgical neck fracture. Okay, I'm putting up Daniel. Perfect. Not radial, Daniel. It is axillary. And I'm also telling you one more thing, guys. Not only fracture of this, not only fracture of the surgical neck, even, you know, sometimes there will be shoulder dislocation. Even in dislocation also, you will have axillary nerve damage. Okay, remember that thing. Even in case of dislocation also, you will have axillary nerve damage. Okay. Yeah, it is a surgical neck. Sohail Khan, it is a surgical neck fracture. It is a surgical neck fracture only, which I have shown you. But I am telling you, not only surgical neck, even dislocation also will lead to axillary nerve damage. Okay, right. Look here, guys. Look here, all of you. Can anyone do this question? The first one. A 48 male returns to your office, right, 8 months after sustaining a proximal humerus fracture. Proximal humerus fracture. What is proximal? This is proximal. What is distal? This is distal. Towards the body is always proximal, right? This is proximal. So that was successfully treated. That was successfully treated. However, he is still having persistent anterior shoulder arm pain that worsens with most activities. Okay. He has not done any physical therapy, not received a corticosteroid injection. What nerve passes along the cervical neck? Can anyone answer now? Perfect, superb. Cyanide, Aniken, HS Vlogs, you all are awesome guys, really. Harshita, Vardhan, Diva, Khan Amin, Vishwas, excellent Vishwas. Axillary nerve. Okay, axillary nerve. Another question for you. Another question for you. If you answer this, I will believe that you understood the topic, guys. A 16-year-old man. Now, this question I have picked it up from USMLE, right? So, uh, look at this question. This is how the questions are asked in your NEET exams, okay, or the next exam. A 16-year-old man is brought to the emergency department for left arm pain. He is having left arm pain. Okay. For the patient, he was playing at his high school football game when a member of the opposing team tackled him from behind. Okay, someone pushed him from behind, which resulted him landing on his left arm. So someone pushed him, so he fell down, right? He was landing on his left arm. Finally, he ended up touching his left arm to the floor. So he had a fracture of neck of the humerus. He was having the fracture of neck of the humerus. Sharp pain at his left shoulder. Fracture of neck of humerus. Sharp pain at his left shoulder. The patient is in mild distress and holds his arm against his abdomen. It means he is holding it like this, right? Physical examination demonstrate limited abduction. Now, I want your attention here. Patient is having limited abduction. Which nerve performs abduction, guys? Which nerve performs this action, abduction? Axillary nerve. Next, reduced muscle tone over the shoulder. What additional finding? What is the additional function? He is indirectly asking what is the additional function. By now you might know that the nerve is axillary. Perfect. But what is the additional function of that nerve? I told you two more functions. What is that? Loss of sensation over the dorsal hand? No. Loss of sensation over the medial one half of the fingers? No. Lateral 3 1/2 of the fingers? No. Loss of sensation over the lateral arm. This is arm. This is forearm. I told you lateral side of the arm, loss of sensation. Answer will be 4. Anjana Paul, you have answered early. Perfect. Perfect. Agya Savlani. Perfect. Harshita, perfect. Ali Mistro. Vishwas, perfect. All of you are perfect. Okay. I'll teach one more topic and give you break, guys. Okay. Right. Cool. Now look at this X-ray, guys. Now look at this. Look at this. Tell me what. I won't ask you what kind of fracture is, because what kind of fracture they will ask you in orthopedics. But they'll ask you here that what nerve can be damaged. Yes. What nerve can be damaged here? Kanamin, come on. Cyanide, Sanyasi Pandit, all of you are right. Aniken, excellent. Because we have got a radial groove. This is called as a mid-shaft fracture, isn't it? This is called as the mid-shaft fracture. Mid-shaft fracture, where the radial nerve will be damaged, and the patient will have wrist drop. Okay. See, guys, for wrist drop, one simple point I'm telling you. If you want to remember, you remember, or else no. Whenever there's wrist drop, right? What should I do? I should elevate the wrist. So I will put a splint here. I will put a splint which will be attached to my fingers, and that is called as cock up splint. Right? The hand will be up like this. This is called cock up splint. I use for radial nerve injuries. Cock up splint. Sir, do we really need to know what is cock-up splint and all in case of anatomy? No, you need not to know. I just told you for your knowledge. Okay. But do I need to know this X-ray? Yes, you need to know because they'll ask you definitely in anatomy. Right, guys. Who will tell me the answer of this question? Harshita, yes, for FMG, they'll ask you splints, okay? I'll tell you, don't worry. Who will tell me what has happened here? Do you see a small piece that is coming out? This is called medial epicondyle fracture. Medial epicondyle fracture. Guys, I have actually kept a blur X-ray, but in the exam you will have a very perfect X-ray, okay? Very clear X-ray. Don't worry about that. I just kept a blur X-ray because I got this, I kept it. But in the exam you'll get a very clear X-ray. Medial epicondyle fracture, ulnar nerve. You know ulnar nerve is called musician's nerve, right? I'll tell you later on. Okay, fine. So, there is no need to put up questions, guys. I know because you will answer all these things. Okay, so this is called wrist drop. All of you know that. Okay, this is called as wrist drop. I just downloaded the images, so I'm putting up to you, or else there is no need to put because all of you are super perfect with all of this. All of you have understood the topic very well. So there is no need to question you again and again, you know. You can do this. So till here, guys, if you really understood whatever I taught you, 4 questions can come. 4 questions can definitely come from these. Okay, 4 questions definitely can come from this. Right. So now let us switch on to the next one. That is your beautiful radius and ulna bone. Radius as well as ulna bone. After this, we shall have a little bit break. Okay, radius as well as ulna bone. Right. We have got 2 bones, radius and ulna. Okay, radius and ulna. Now, I'll tell you the schedule. HS vlogs, I'll tell you the schedule also for my classes and all, right? So regarding the radius and ulna, guys, this is the humerus. I'm just drawing it roughly. Okay. Right. So this will be your radius bone. This will be your ulna bone. Okay. In between the radius and ulna, whatever you have, this is called as the interosseous membrane. Between the 2 bones, in between ossea, 2 bones, interosseous membrane. Interosseous membrane. Interosseous membrane. So guys, what I want you to tell is that whenever I discuss radius and ulna, okay, only 3 important MCQs will be asked every time. Only 3 MCQs. Okay, 3 MCQs. Other than that, they won't ask you anything. Believe me. Only 3 MCQs. What are those 3 MCQs are? What is Colles fracture? What is Smith fracture? And there is a deformity called as Madelung deformity. What is Colles, what is Smith, what is Madelung deformity? So these are the 3 things they'll ask you, guys. See, what is this is Colles fracture, Smith fracture. In both of them, there is fracture of radius bone. So if I'm putting my hand like this will be my ulna bone, this will be my radius bone. So exactly at this point, the distal radius, if there is a fracture of distal radius, you call it as Colles and Smith. But the important thing is that the X-rays of Colles and Smith will be different. Okay, Colles fracture. Look here. How do I explain Colles fracture? For example, this is my radius bone. If there is a fracture of radius and if the radius is pointing downwards, this is called Colles. If the radius is pointing upwards, this is called Smith. Very, very simple. Okay. So if, look here, if radius is downwards, down, that is called Colles. If the radius is up, that is called Smith. I'll show you. I'll show you this thing, the X-ray. You will understand very clearly, guys. Now look at this X-ray here. Look at this X-ray. Let me tell you one thing, that see, this bone is your radius bone. Okay. Now tell me, this is the line. Radius is downwards or upwards? Radius bone is pointing down or pointing up? Be fast. What happened? Cornoli, right? Diva, right? HS flocks, it is not up. It is down, down. Down, down, everyone. Dr. Bendick, not up. It is down. Look here, look here. Look here. It is downwards, right? It is downwards like this. It is downwards. Okay. See, I'm making a straight line. See, radius is downwards. The remaining part is upwards, but the radius is pointing downwards here. Very good, Sohail Khan. Down anteriorly. Right? Downward it is what? What is downward? Downward is Colles fracture. Colles fracture. Downward is Colles fracture. Madhavan, you're right. Okay. Again, I'm telling you, if the radius is pointing downward, okay, let me show you Smith. You will understand. Right. Now compare these two guys. Compare these two things. Now look here, radius is pointing upward now. Radius is pointing upward. Look at the previous picture. Look at the previous picture. I'm rubbing it out. Look at the previous picture. The radius was pointing downward. Now the radius is pointing upward. So upward is called what? Smith or Colles? Excellent. Excellent, Sannyasi. It is Smith. It is Smith. You understood? You understood, right? Now you will tell me again. What is this? Radius is pointing upward or downward? Tell me, it is upward Smith or downward Colles? Yes? Anjana Paul, it is not Smith, not Smith. Harshita, not Smith. Look here, it is facing downwards. Very good. Here it was facing upwards. Here it was facing downwards. So Colles. Okay. Excellent, guys. This is Colles. This is Colles. This is Colles. Perfect, perfect, and perfect. Perfect. Very good. Sohail Khan, perfect. Birapan, perfect. Rajeshwari, excellent. Right. So, these two questions. Third question is made-lung deformity. What is made-lung deformity is? What is made-lung deformity is? Very simply, I'm telling you guys. Look here. I mean, there are many theories, you know. There are many theories for that. I don't want to go for all of them. You have got carpal bones like this. Let us say this is radius, this is ulna. Carpal bones like scaphoid, lunate, pisiform, right? Triquetrum, right? So these are the bones. See, guys, there is a theory that there is a ligament. There is a ligament. All of you listen. All of you listen. There is a ligament that is attached from radius to ulna. There is a ligament that is attached to radius to ulna. This is called, sorry, radius to lunate. I'm sorry, radius to lunate. This is called as radiolunate ligament. This is called radiolunate ligament. Radiolunate ligament, or the other name for this is Vickers ligament. Vickers ligament. What is the other name? It is Vickers ligament. So what happens is that this ligament will hold the radius so tightly. Simple thing, guys. All of you look, simple thing. For example, I am tying a rope to an animal and I'm holding it. I'm not moving. I'm in the center point. I'm holding it. Can the animal go away from the radius? No. If the animal wanted to go, it will make a turn around me, isn't it? When I'm holding it like this, the animal will make a turn like this. It will turn around me. Or it can come to me, but it cannot go out of the length of the rope. So what will happen in that case? What will happen is that as this lunate bone with the help of this ligament is attached to the radius, it is catching hold of the radius. So as the radius is developing, it will take a turn like this. The radius will take a turn. This is called bowing of radius. The radius will bow like this. If you look at the picture, you'll understand. The radius will bow. Right? I think I don't have a picture. Right, but anyways, I'll put up a picture. Uh, Give me a second. Right. Yes, look at the picture now, guys. Look at the picture. Look at this picture now. I'm putting it up to you. All of you look here. Can you find something wrong here? The radius bone has taken a curve like this, isn't it? The radius bone has taken a curve. So this is called as made-lung deformity. What is this called? This is called as made-lung deformity. Made-lung deformity. Okay. This is because of this Vickers ligament. I hope you understood. Yes, this is physiological, Roy. It will be fine again. When you put a cast there, it will be fine again. Schedule, Sohail, I'll share it immediately. Careless, when we can get your whole lectures. I'll teach this, but anyways, I'm recording all the lectures, so you can get it in an app which will be released very soon, right? Khan Amin, yes, sure, Khan, definitely, right? So we are done with this, right? We are done with these things. So I hope you practiced enough. Now, after the break, guys, after the break, I will teach you the carpal bones. Okay. I'm pretty sure you know the carpal bones, but I have to teach as a rule. I'll teach very fastly the carpal bones, and next we'll enter into the real thing, that is the muscles. Okay. I'll teach you each and every muscle in detail, and even clinically, I'll orient it and I'll teach you. Okay. Let's have a break. Hello guys, welcome back, welcome back, welcome back. Right. All of you are there? All of you, all of you, all of you. Welcome, fine. Khan Amin told welcome, so we shall start now. Welcome, thank you, thank you, thank you. So, Harshita asked me a question, right? What about Gilesi fracture? See, Gilesi fracture and all, you'll study in orthopedics, right? They won't ask you in anatomy because those all are completely orthopedics, okay? Gilesi fracture is nothing but I told you fracture here, right? Fracture here was this Colles and Smith. Gilesi means here in the middle part. The same thing, fracture of radius in the middle part, Gilesi. Opposite of that will be Monteggia fracture. Opposite of Gilesi will be Monteggia, but that is not important. If it is important, I would have told you. That is not important right now, okay? Those are deeper discussions of fractures which we will study in orthopedics, okay? But right now we shall discuss about what? The muscles. Okay, we shall discuss about the muscles. But before muscles, I promise that I told you very fastly we shall discuss the carpal bones. Okay, very fastly, because I hope all of you know about carpal bones. So as usual, radius, ulna, right? And carpal bones, she likes to play, try to catch her. Now everyone has got their own mnemonic, guys. I studied this mnemonic, right? If you study any other mnemonic, then that is well and good, okay? That is well and good. Sir, please cover however to easily learn. Sarvesh, please be with me till the session. I will teach you the forearm muscles. I'm telling you, in the session itself, you will be perfect with all the forearm muscles. So there no need of mnemonics. Without any mnemonic, without any much memory, just 1% memory, I'll teach you the forearm muscles perfectly, okay? Just believe me. Right. So what does S stand for? S stands for scaphoid. S stands for scaphoid. Now, wherever there is radius, that is called lateral side. It means this will be by lateral, lateral and lateral to medial. These are the bones, right? So, what does S stand for? S stands for my scaphoid bone. Scaphoid. L stands for lunate bone. Are you simply writing, or T stands for triquetrum? Are you simply writing, or will you tell any important points? Yes, I'll tell you important points. What are the important points? Are the most common carpal bone which is fractured is scaphoid. Okay, so this is the most common carpal bone fractured. Carpal bone fracture, most common. Then what is the second most common? Second most common carpal bone fracture is second most common fracture of carpal bone is lunate. Lunate means moon. Luna means moon. Moon shaped bone. Okay. Equatrum. Next, we have got pisiform bone. A small bone like a peanut, pisiform. Right. So this is also called as what bone? Can anyone tell pisiform is called as? Pisiform is called as what kind of bone, guys? Roy, excellent. Perfect, Roy. Sesamoid bone. You are right, Roy. Sesamoid bone. Sesamoid bone. Right? Upper four are finished in the upper row. Now in the lower row, T stands for trapezium. T stands for trapezoid. C stands for capitate. Capitate. Okay. C stands for capitate. Any new things here also? Capitate is the largest carpal bone. It is the largest carpal bone. Capitate is the largest carpal bone, right? Next, after capitate, we have got hamate. Hamate, H for hook, right? Hamate has got a hook. It has got a small hook like thing like this. Hamate has got a hook. So hook shaped bone or a bone which has got hook is called hamate. So I think this is enough, guys. This is enough regarding this. MCQs will be covered. If you don't trust me, I'll also make you to do MCQs. Look here. You see here. In 2017 FMGE exam, they asked which carpal bone has got a hook. Now you will answer it very perfectly, but after studying all the 19 subjects and when you finally enter into the exam, this will be the most difficult question. That is why I'm telling you again and again, revise, revise and revise. Which has got a hook? H for hamate. So hamate bone has got a hook. Right? Which is the first carpal bone to ossify, guys? Anyone, any idea? First carpal bone to ossify? Come on, answer fast so that I can teach you fastly the remaining important things. No idea? Come on. And one more thing, guys, we have just created a Telegram group where I will be posting all my notes and everything there. Okay, so there is a link provided there. I want all of you to join there so that all these notes will be included there. Okay, all these notes will be included. Yes, come on. Yeah, obviously capitate will be the answer. Yeah. So which is not part of proximal row of carpal bones. So we have got two rows. So here there is one row, here there is one row. So the lower row, see, we have got two rows, my index finger, my middle finger. Index finger represents one row, the middle finger represents second row, but middle finger is what? Where it is towards my body. It is proximal to my body, whereas my index finger is upward, distal. So he is asking proximal row, which is not a part of proximal row. Excellent. Ahmad Alif, excellent, guys. D. You see, such simple questions will be asked, guys. This is not a very big, that exam is a very simple exam. And they will also ask you the image based questions. Identify the marked bone. See, all of you know this is humerus. Now, what are these two bones? What is this A bone called? He is asking what is this bone? What is this bone called? Radius or ulna? Yeah. Excellent. That is called radius. Ulna is the one which fixes into the olecranon fossa. Okay. So this is called radius. It is a radial head. Okay. It is called radial head. Right. So let us go further now. Right. Now we shall start discussing the muscles. I want all of you to pay utmost attention, guys. Utmost attention. All of you just pay attention. Aditya Raj, you are right. Addy Hazard, you're right. Veerappa, you're right. Sri Harika, radial head, perfect. So we shall discuss about the muscles. Along with the muscles, we shall discuss the nerve innervation and the arterial supply. So in the upper limb, we have got many muscles, guys. Some muscles located here, these are called as pectoral muscles. Pectoral muscles. Some muscles are located in the back. These are called as back muscles. Some muscles are located on the scapula. These are called scapular muscles. And what did I tell you? See, this is called as arm. This is called as shoulder, arm, forearm, hand. Hand in the sense not the entire thing. Only this is called hand. Other name for hand is manus. Okay. Arm, forearm and hand. So, arm, forearm as well as hand. arm, forearm as well as hand. You understood this? Yeah, very good. Now we shall first discuss the major part and then we shall look at the remaining parts. Okay, we shall discuss the major part. What is the major part is that first we shall discuss the muscles of back because many clinical points are here. Now I want all of you to put your pens and pencils down. Just look at what I'm teaching you. Just look at what I'm teaching you. Okay, look here. I'm drawing the back of the skull. I'm just drawing the back portion of the skull. On the back of the skull, if you put your finger, you will find something. This is called nuchal tuberosity. This is called nuchal tuberosity, right? So this part is called as nuchal line. Now from there, the spinal segments start, guys. C1, we have got C2, C3. I'm not writing all of them, don't worry. Let us say C6. I'm skipping some things in between. Okay, C6. We have got C7 and we have got T1, T2, T3, directly T5, T6, okay, and T7, T9, T10 and T12, L1, L4, L5. Okay, I'm not drawing all of them. I've just written few. Let me also mention this thing. Where is T6? This is T6, right? And where is T1? This is T1. Now you must be familiar, super familiar with the pictures which I'm drawing right now, right? All of you are familiar with those pictures. Okay, and all of you know in the center we have got a sulcus here. What is that? This is called bicipital groove. So I'm just minimizing a picture and showing you. Simple thing, guys. A person is standing like this, right? From the back side, I have written all these spinal segments, and on the right side, this is his right scapula and this is his right arm. Okay, right shoulder arm. I mean the humerus. Okay, the same things. Now look, there is a muscle. There is a muscle which starts all the way from the nuchal line here, which starts all the way from the nuchal tuberosity. Okay, now this muscle originates from the nuchal tuberosity, then all the cervical segments, next it is coming till all the thoracic segments. This muscle originates from nuchal tuberosity, from C1 till C7, from T1 till T12. Okay, this muscle is attached in this way. This muscle is attached in this way. Okay, this muscle is attached in this way. Now this muscle has got three fibers. This muscle has got three fibers. Now what are these fibers are? Some group of fibers are attached like this. Some group of fibers are attached like this. Clear? I'll explain you clearly. Just concentrate here. Now these are a group of fibers which are attached to where? They are attached here on the top. They are attached on the top as well as the acromion bone, on the acromion spine of the spinous process. It is also attached to the spinous process as well as on the top here. Okay, also attached to the spinous process as well as on the top. So this entire muscle which I have just drawn is called as your trapezius muscle. What is this muscle? Trapezius muscle. So if I ask you the origin and insertion, origin of this trapezius muscle is from nuchal tuberosity. Should I remember origin and insertion for next exam? No. Should I remember origins and insertions for MBBS first year? Yes, you have to remember. So nuchal tuberosity, C1 to C7, T1 to T12. And where is it inserting? Listen very carefully. This trapezius muscle has got three types of fibers. The superior fibers are attached to the acromion process. The middle group of fibers, there are middle group of fibers. These middle group of fibers are attached to the medial angle of scapula, right? They are attached to what? Medial angle of scapula, medial scapula. And inferior group of fibers, they are attached to the inferior angle of scapula, inferior angle of scapula. So what are these fibers? Superior fibers, middle fibers, inferior fibers. So these all three fibers together, I call it as trapezius muscle. So why are you telling me this? Why am I telling you this is, for example, if the superior muscles are contracting, superior muscles are attached like this, medial are attached like this, inferior are attached like this. If superior muscle is contracting, scapula will move upward. Scapula will move upward. If I'm contracting, scapula is moving upward. So can I tell the function of trapezius is, the first function is elevation of scapula, elevation of scapula. Second function, the medial group of fibers are attached like this, right? The medial fibers are attached like this. If I'm pulling them, the scapula moves like this. It means my scapula is moving like this. This is called retraction of scapula, right? This is called retraction of scapula. And third is that inferior groups of fibers are attached in this way. Inferior groups of fibers are attached in this way. If I'm pulling the scapula will move downward like this. So this is called depression of scapula. This is called depression of scapula. Simple thing, guys. Right now you came to know many important MCQs. Elevation, retraction and depression of scapula is done by a single muscle, that is trapezius muscle. That is what? Trapezius muscle. Okay? It is called trapezius muscle. So the first muscle of the back, the first muscle in the back we studied is trapezius. I'll make a box later, trapezius. Now look at the next muscle. Look at the next muscle. Look at the next muscle. Before I draw next muscle, look here. Right. Before I draw next muscle, I'll draw the next muscle with the pink. Look here. This muscle originates from T12. From T12 it is starting, coming all the way down till T4, L4, L5, right? And look here, this muscle is also starting from the sacrum and all the way till the iliac crest in this way. Now this muscle, look here, above it goes all the way up, it goes all the way up till T6. So if I ask origin of this muscle, what will you tell? Origin of this muscle is all the way from T6 till T12, L1 to L5, and it is also covering half part of sacrum. It is also covering iliac crest. Right? So this muscle now, all the way it goes and attaches to your, where it is attaching? It is attaching to your bicipital groove. So this is the thickness of the muscle. This is the entire muscle like this, attaching to bicipital groove. And this muscle is present on the dorsal side, right? It is present on the dorsal side. You call it as latissimus dorsi. This muscle is called latissimus dorsi. Okay? So you might get a doubt. You can even just tell us what is trapezius, what is latissimus dorsi. Now, why did you waste a lot of time telling this? The reason is that wherever this latissimus dorsi and wherever this trapezius muscle is overlapping each other, at one point you don't find any overlappings. You see here, exactly at this point there is no overlapping. There is an empty space here. there is a triangle here. This triangle, which is formed by the overlapping of latissimus dorsi over the trapezius, this triangle you call it as triangle of auscultation. Triangle of auscultation. At this point, if you put a stethoscope and try to auscultate the patient lungs, very clearly you can listen to the sounds. Okay, so this is called as triangle of auscultation. You know how important this MCQ is, that guys? How important this MCQ? I'll put 20 stars over here, but still this MCQ needs more than this. Very, very, very important, guys. Very, very, very important. Okay, very important. Yes, Roy, you're right. You're right. So this triangle of auscultation, what questions will they ask? They will ask the borders. Borders of triangle. What are the borders of triangle? I've got three borders: superior border, inferior border, lateral border. Okay, look here now. All of you pay attention now. Look here. This border is called as the lateral border. Okay. This border is called as a superior border. This border is called as the inferior border. So laterally, what bone I have? Everyone, you're right, Bentek, you're right. Laterally, what do I have? Which bone do I have? Lateral border of this triangle is having what? Lateral border of this triangle is formed by which bone? Birappa, you are right. Lateral border is formed by scapula. Lateral border is formed by scapula. And tell me, inferior border is formed by which muscle? Ishakor, you are right. Dr. Bendik, you are right. Inferior is formed by which muscle? Latissimus dorsi. Very good. It is formed by latissimus dorsi. And superior border is formed by which muscle here? Look and tell me. Superior border is formed by inferior border of trapezius. Okay? Trapezius muscle. Okay? Trapezius muscle. Everyone clear with this? I hope you are clear with this. Okay? Another important here itself, guys, here itself another important thing I'm telling you, that on the anterior side of the abdomen, I have got some muscles. Transverse abdominis I have, internal oblique I have, external oblique also I have. Okay? But from the back side, if you are wishing to see muscles on the anterior side, you can't see. But you can see one muscle which is crossing like this. Okay? Crossing the abdomen. I'll show you from the back how it looks in the front. So this is the muscle, guys. This muscle is called as external oblique muscle. External oblique muscle. This muscle is called external oblique muscle. Now, again I will get a triangle here. Again I'm getting a triangle. What is this triangle, guys? Look at this triangle. This triangle, this is the triangle here. This triangle, one side it is having what? Latissimus dorsi. One side it is having external oblique, and down it is having iliac crest. Iliac crest, external oblique, latissimus dorsi. Three of them together you find a triangle called as Petit's triangle. This triangle you call it as lumbar triangle. Lumbar triangle, or the other name for this is Petit's triangle. You know why it is important? Most commonly, the lumbar hernias happen here. This is also called as lumbar hernia or Petit's hernia. Okay, so what will happen here? There will be lumbar hernia or Petit's hernia. lumbar hernia or Petit's hernia. So guys, did you understand whatever I taught you guys so far regarding the back muscles? We have discussed back muscles like trapezius. We have discussed latissimus dorsi. We have discussed the MCQs also, which can be asked from here, right? We have also discussed only two muscles, right? Latissimus dorsi as well as trapezius, and we have discussed all the clinical important points related with this. Did you understand, guys? Did you understand this explanation? Did you understand those two triangles perfectly? I'm not writing the borders of Petit's triangle because by now you know, by looking at this picture, what will be the borders of Petit's triangle. You understood, right? Rami Ibrahim, thank you. Isha Kaur, yes. Roy, yes. HS Vlogs, yes. Thank you. Thank you so much. Okay. You keep on commenting, okay? So I'll in the meanwhile I'll draw one more important thing. I want you to know that did you understand or not? C1, C2. Now we are closing up the discussion of back muscles with one last picture. Right. This doesn't look like a scapula, but you know, you just have to imagine everything. That's what I told you in the starting, right? So, look here, guys. I'm talking about another back muscles, the remaining back muscles. Look, from C1, C2, C3, C4. From C1, C2, C3, C4, there is a muscle that is coming like this from C1, C2, C3, C4. If you want me to go so straight, so detailedly, from transverse processes of C1, C2, C3, C4. Okay, every vertebra has got a transverse process like this. So from these transverse processes of C1, C2, C3, C4, I got a muscle that is attaching on the top of the scapula. Top of the scapula. Now, this muscle, guys, this muscle, Roy, you are right. You are right. You need not to guess. You are right. You are perfectly right. Now, this muscle is attaching to the top of the scapula. When I'm contracting this muscle, what will happen to the scapula? Will it elevate or depress? Tell me. Will it elevate or depress? Rami Ibrahim, you're right. Roy, you're right. Elevate. It will elevate, right? The scapula will elevate. So, elevation of scapula is called levation. It is called levation, and the name of this is levator scapulae. Levator scapulae, originating from C1 to C4. Next, next. There is another muscle. There is another muscle. Now watch very carefully, guys. Watch very carefully. I don't want you to remember and by heart the muscles. That's why I'm teaching you with the help of functions so that the names would be easy. All the way from T2, T3, T4, T5, you get a muscle that is attached to the inferior angle of scapula like this. Not inferior, medially only, right? Medially only. It is attaching here, medially only. But this one, this muscle is like a rhomboid, isn't it? This muscle is like a rhomboid. And there is also one more muscle from C7, T1 also attached in this way. This muscle is also in the shape of a rhomboid, but one is major, one is small. So I'll call it as major rhomboid and minor rhomboid. Major rhomboid and minor rhomboid, right? So what all we discussed? We have discussed, we have got a major rhomboid, we have got minor rhomboid, right? We have also got what? Levator scapulae. Right. Your all answers are right, guys. Your answers are perfectly right. Your answers are right. Excellent. Nice. So what all muscles do I have on the back? Trapezius, latissimus dorsi, major rhomboid, minor rhomboid, and levator scapulae. So Ali Mistro, you want me to explain the function of latissimus dorsi? Latissimus dorsi here. See, I told you that latissimus dorsi is responsible for forming a triangle that is called as triangle of auscultation. Okay, and latissimus dorsi is inserting to bicipital groove. Bicipital groove. Okay, and you know, all of you guys, whenever you are lifting heavy weights, you get lower back pain. You know why? First thing is that weight is impended onto the lower back. Why weight is impended onto the lower back? When I'm lifting heavy weight, what will happen is that all the pressure, whatever I'm lifting, is impended upon my humerus. And humerus has got a muscle called latissimus dorsi that goes all the way and attaches to the lower back, right? That is the reason why whenever I'm lifting heavy weights, I'll have lower back pain. Okay, lower back pain. So you understood till here. Now, a very important MCQ, that now you will answer me because you know this already. I told you we have got a groove like this. This is called bicipital groove. Bicipital groove has got two lips. One is called as medial lip, another one is called as lateral lip. Now you will tell me, I have discussed this already. This is called medial lip. Which muscle attaches to medial lip? Together I am putting up these MCQs. Which muscle is attached to medial lip? And this is your lateral lip. I told you, medial lip or lateral lip, majors are attached. Sannyasi Pandit, you are right. Remember it as MET. T stands for ME and T. T stands for teres major. Teres major. And lateral lip also one more major. What is that major? Pectoralis major. Pectoralis major. And in the bicipital groove, I have got what? Latissimus dorsi. So can I tell like this? There is a lady sitting in the center between two majors. This lady is nothing but latissimus dorsi. Two majors are nothing but teres major, pectoralis major. Lady between two majors. That was the thing someone told me in the starting. Lady between two major. This is a high yield MCQ. You know, wherever there is a confusing part, that will be an MCQ because they have to filter the students out, right? So they'll definitely ask you these confusing questions. So this is a very high yield MCQ. Okay, very yeah, Roy, latissimus dorsi sandwiched between these two, but in India we basically use these things like lady between two majors and all, right? So sandwich is mostly the foreign culture, right? So there you use that thing, right? And one thing we forgot, you know what, we didn't discuss the nerve supply. Very easy. Nerve supply is very easy. Nervous supply is very easy. Simply remember a mnemonic TAN. Okay, TAN. T stands for trapezius. AN stands for axillary nerve. Trapezius is accessory nerve. Accessory nerve. That's it. The remaining all are finished. What are the remaining? Latissimus dorsi. Where is this latissimus dorsi? In the dorsal side. Dorsal side, name any nerve which starts with dorsalis like this. What is that? Latissimus dorsi is located in the thoracic region. I mean, exactly here, right? But in the dorsal part. So can I call this as thoracoldorsalis, right? So a nerve is called as thoracodorsal nerve. thoracodorsal nerve. Okay. See, major and minor rhomboid are attached to scapula. Okay, are attached to scapula. But where they are attached to scapula? On the ventral side or on the dorsal side? Look in the picture. Wherever there is spine, that is a dorsal side. They are attached onto the dorsal side of the scapula. So can I call it as dorsal scapular nerve? Can I call it as dorsal scapular nerve? Right? Okay, fine, sir. So you told me major and minor are attached to dorsal side of scapula. You are calling it as dorsal scapular nerve. Then levator scapula is also attached to dorsal side of scapula. Then what nerve will you name it? The nerve here also it is the same, dorsal scapular nerve. Dorsal scapular nerve. Nerve innervation is done. We are done with the nerve innervation. We are done with the nerve innervation. Again dorsal scapular. Yes, Roy, you're right. You're perfectly right, Roy. So we are officially done with the explanation of the back muscles. Okay, we are done with the explanation of back muscles. Clear? Now, did you understand the explanation of back muscles, guys? Because the remaining muscles like pectoralis, scapular, arm, forearm, someone asked me forearm. I will definitely tell you very interestingly, because if I start the next session, I'll start with the forearm only, right? Head and neck also, Isha core, I'll also teach you head and neck, okay? Head and neck also definitely I will teach you. I will teach you head and neck also. Okay. So let us look at, Ali Misra is asking about long thoracic nerve. Let us look at another group, okay? For example, let us look at the pectoralis very fastly, 5 minutes topic. Very fastly it will complete. I'll just tell you the things in pectoral. Very fastly it will complete, okay? Pectoral region. Tell me guys, will it be difficult for you to remember 2P, 2S? 2P, 2S? No, it is not difficult, right? Remember it as 2P, 2S. In pectoral region, you will have muscles by name called as pectoralis, right? So what are the two pectoralis? There is pectoralis major. I told you previously, wherever there is major, there will be minor. Wherever there is longus, there will be brevis. So pectoralis major. Then I will have pectoralis minor. Very simple. Pectoralis minor. Okay. Pectoralis major. Pectoralis minor. Okay. Pectoralis major and pectoralis minor. What are the two S muscles? One is called subclavius. Another one is called as serratus anterior. Remember one thing, serratus anterior is called as your boxing muscle, boxer's muscle, boxer's muscle. So if any one of you don't know how this serratus anterior looks, I don't have a picture as well, right? But I'll try to put up something, right? I'll show you later on. Serratus anterior, see this is serratus anterior. Here you will have the serratus muscles, okay? These are serratus anterior muscles, okay? Serratus anterior muscles. Now look here guys, look here, one very important thing. Nerve supply I will tell you, but look here. This is your sternum, isn't it? This is your, this one only, the clavicle. Okay, fine. Okay, you have got two lips, medial lip, lateral lip. Now there is a muscle that starts just below the clavicle like this. It continues till the sternum, head of the sternum, that is manubrium. It continues along the sternum like this, down till where? Till 1, 2, 3, 4, 5, 6, 7, 8, till the first 8 ribs. Okay, till the first 8 ribs, and then all the way it goes and attaches to your lateral lip, like this, lateral lip. Lateral lip means by now you might know that I'm talking about pectoralis major muscle. Pectoralis major muscle. Why did I draw? Why did I draw is to explain you one thing. What is this is a very famous muscle, guys. This is a very famous muscle. Why, you know? Because it has got 3 functions. F stands for flexion. F stands for flexion. And A stands for adduction. Now you might get a doubt, sir, how to remember adduction. Simple thing, guys. Pectoralis major. My hand is pectoralis major. It is catching this humerus. Now I'm pulling it. When I'm pulling it, my humerus is coming inward. It means towards the body, adduction. And M stands for medial rotation. Medial rotation. Okay? Medial rotation. Right. Next important thing is that serratus anterior. I already told you that, I did not tell you, I think, right? Serratus anterior. Serratus anterior is supplied by long thoracic nerve. Long thoracic nerve. If long thoracic nerve is damaged, then serratus anterior muscle won't work, and what will happen? The scapula will droop downward, right? So this is called drooping of scapula or winging of scapula. Winging of scapula. You just have to remember it at any cost. At any cost, you just have to remember it, because 100% if you write 5 exams, out of any 5 exam, 1 exam definitely you will get this question, drooping of scapula. Okay, drooping of scapula or winging of scapula. You see, already question has been asked, image based question, you know. Look at this, look at this. Which nerve is involved in this presentation? Tell me. A, B, C, D. Anjana Paul, I teach immunology. Yes, I teach immunology, Anjana. I will also teach you, don't worry. Microbiology, micros class, I will also teach micro, not only anatomy, right? I will also have micro in the further. I will also have micro. But one important thing is that I have already recorded micro lectures, and soon we are about to release an app. So you will find all the microbiology lectures over there. But still, I'll be teaching the important things on the live sessions. Okay. So tell me the answer here. Very good. Excellent, Ahmed. Roy, excellent. Namomina, excellent. It is long thoracic nerve. What is this? Long thoracic nerve. Very good. Long thoracic nerve. Right? You know how many times this question has been asked? I'll show you. Look. Winging of scapula is due to damage of long thoracic nerve. Winging of scapula is due to paralysis of which muscle? Serratus anterior muscle. Winging of scapula is due to the paralysis of, again, serratus anterior muscle. So many times this question has been asked. Okay, keep this thing in mind. This question has been asked many times. Okay, right. So we discussed pectoralis major. If I remove pectoralis major, I will find pectoralis minor. Okay, subclavius, sub means below, clavius means clavicle. Just beneath the clavicle you will have that is called subclavius. Serratus anterior, I told you. MCQ also I told you. But can you please tell me the nerve innervation? Now before I tell you nerve innervation, all of you know alphabets, right? You know A, B, C, D, E, F, G. You also know L, M, N, O, P, Q, R, S, T, right? You also know L, M, N, O, P, Q, R, S, T, and so on. Now what does L stand for? L stand for pectoral nerve, but L means lateral and medial pectoral nerve. Lateral and medial pectoral nerve. Then what does M stand for? M stand for medial pectoral nerve. Medial pectoral is common because we are supplying pectoralis muscles. Pectoral should be common. What is N? N means nerve to subclavius. Nerve to Subclavius. What is O? Need not mention, I think, right? O means long O. O you have there. That is long thoracic nerve. Long thoracic nerve, need not to mention this. Right, guys? So remaining we shall do it in the next session. But please tell me, again, I'm asking you for the feedback. Is this session worthy for you? Right? Immediately after this session, I'll post the notes in the Telegram group. But is this session worthy for you guys? Yes. And soon, guys, we are also starting sessions on patho, on pharmacology, right? So we'll also start there. But tell me, is this session worthy? Simple thing, guys, the way you learn, see, even I don't remember all these things. So how do I see? Even before the lecture, I practice a lot because I've taught this 100 times. But still, before the lecture, I have to look at that because revision is more important. Okay, when you revise, and revise, you will never ever forget. Revision is more important. But what I'm telling is that to reduce your memory, to reduce your memory consumption, you have to look at the pictures. Okay, look at the picture and learn whatever subject it might be. It will be really easy for you. I'll send all the notes, whatever I've taught you today. Okay. Telegram link, already it was posted, but again we'll post in the comment section. But all of you, was it worthy, right? Roy, thank you so much. It would be much more easy, Roy. Believe me. What I feel personally is that so far, whatever topics I've taught you are little bit difficult topics, difficult to understand. But the remaining topics which I'm going to teach you, like forearm, hand, arm, they are going to be super easy, and super easy. Believe me, right? So they will be really interesting for you because many clinical points I'll be discussing there. Mahendra Sharma, mycology, we started with bacteriology, we'll finish up, then we shall study virology, then mycology and parasitology, okay? Right? I'll send all the notes, Namo Meena, I'll send all the notes. Okay? Thank you so much. And one thing, guys, one thing is that after this session, I want you to, I don't want you to trouble you, but put the video at 1.5x speed or whatever it is, make notes, revise them, okay? Revise them and maintain a separate book for microbiology as well as the anatomy part which I'm teaching, okay? Even in micro also, I will include all the clinical points and questions as well. Right, guys? So, thank you so much for your love. You have given your time for me, right? For me to teach, to listen to my lecture. Thank you so much. Goodbye.